All right, welcome everyone. Great to be here today. I'm Rob Tatro, President, Founder of the Canadian CMV Foundation and of CMV Canada. We got a wonderful morning or afternoon, depending on where you are, lined up for you. It's going to be fantastic. I'm thrilled to have our guests on from south of the border. They're going to be awesome. They're going to chat about, I'll introduce them in a sec, but first of all, there's been, I just want to thank all of you out there, the viewers, the donors, the supporters for what's been a fantastic 2020 year. Thank you to all for coming in big numbers here to the CMV-LIVE. It's been really fun, and we're just getting started. Today is about the halfway point of the CMV-LIVE series, so I'm really excited. I'm going to bring in our guest speakers today right away. I'll bring in Whitney Wunderlich. I will bring in Abbey Sidebottom, and I'm going to bring in Dr. Mark Schleiss. Welcome to all of you.
Hi. Hey.
Thank you. Yes.
It's pretty neat. I was chatting with Dr. Mark Schleiss, just before we were live here, and I was saying how he was an inspiration to me. I forget if it was in Atlanta or if it was in Utah, or I forget. At one of the conferences I met you, I remember you kind of took me aside. I was a young parent. I'm still young, but I was a young parent, and you were like, Rob, you're doing great work. You're doing great advocacy. Keep it up. You're doing great. You're going to get there. It was one of those times when you feel like you're lobbying and you're trying to do all this. You're trying to raise money and nothing's happening. And I remember you were such a positive influence to me. I even reached out to you afterwards, and you replied to my email. So thank you for that. You guys have been great. Now, I don't think I've met Wendy and Abby. I'm not sure. I don't think so, right?
No.
All right. I'm sure you're great people as well, and I'm thrilled to have you guys here. So today we're doing a bit of a deep dive into it's the saliva comparison, right? It's the comparison between tests and how to actually screen for CMV. A lot has been talked about in this space in the past while. So I'm not the expert on this. I'm going to kind of set aside and let you chat about this. But before I do that, I do want to thank our sponsors, which, we can't do this without our sponsors. CMV Canada, Merck. Merck has been fantastic. The National CMV Foundation, our American friends south of the border, they're awesome. NCHAM, that's the National Center for Hearing and Assessment Management, I think, if I got that right. I should get that right. That's in Utah. They're awesome people as well. So a wonderful crew that puts this together. As a reminder, if you're watching, please take a sec to subscribe. Go to our Facebook page. If you're watching on Facebook now, like, share, tell your friends about this. You're talking about CMV. This is neat. This is important. Now, if you're watching on YouTube, take a sec to subscribe to our channel. We put out some wonderful content every 2 weeks right here. Now we're taking a break for Christmas in 2 weeks, but after that, we're back on the first Wednesday of January. So that's going to be back. So every 2 weeks from now until probably March. And remember why we're doing this. We're doing this because all these wonderful presenters were slated to speak at Ottawa at the CMV Public Health and Policy Conference in August. That got canceled because of COVID. Now, I shouldn't say canceled, got pushed back. It's scheduled for Ottawa 2021. This was going to be one of our wonderful topics. And so we're presenting the speakers that we're going to present. We're doing it remotely. We're doing it live. You're at home. You're on your lunch hour. Maybe you're at work. I don't know. But thanks for tuning in. And I will move over and I will give the floor to our presenters. Thank you, guys. I will be back after, and I will ask the audience questions. I'll ask you questions as well.
Okay, well, thank you guys for listening today, and thank you for my community lab. So today we're going to be talking to you about the use of the saliva samples to test for congenital cytomegalovirus with CMV infection in newborns. And specifically today, we're going to look at some of the false positive saliva samples that we found from our study. So presenting today is Abbey Sidebottom, myself, Whitney Wunderlich, and then Mark Schleiss. But I want to give credit to the others listed here on this slide from the Department of Health, the University of Minnesota, and Alina Health, who've helped with this work as well. So, all right, so today we're going to talk to you a little bit about our large multi-site universal screening study utilizing saliva specimen testing for congenital CMV infection, and that's an ongoing study. We're going to talk to you a little bit about our prevalence of false positive saliva PCR results so far. and then the potential impact of donor milk on saliva PCR results and that association that we've found, and digging a little bit deeper into that. So a little bit just about our study, still in progress here, and it's taking place in Minnesota with the universal screening study. And so the prospective study, we started back in 2016 with the first sites from the University of Minnesota. And then later we added in 2017, Allina Health, a couple different hospitals from there. And then this year we actually added a sixth location. But this presentation and the data that we're going to share is just centered around the 5 hospitals in Twin Cities that from Allina Health and the University of Minnesota. And then our recruitment goal is 30,000 newborns, and we're happy to say we're about halfway there right now. So just a little bit about the study. So like Rob mentioned, we're looking at the clinical sensitivity of PCR testing on the newborn dried blood spots, or the blood that's collected from every newborn in the state, versus the saliva specimen that we collect. So we're trying to see which of those two would be the best for implementation of universal newborn screening program. So when families are approached, what they're agreeing to is allowing us to use their newborn's dried blood spots. So for every newborn in the state of Minnesota, we already collect that blood and test for about 60 diseases and viruses with the Minnesota Department of Health. And so they just get permission for us to do an additional test for congenital CMV on that. And then they just allow us to collect that saliva sample from their newborn, test it for CMV. If we find any abnormal results, the Department of Health is allowed to notify their pediatrician of that. And then and we'll talk a little bit more about the notification process. And then they also agree if there are abnormal results that we study staff can review the medical record of the child for up to 4 years to kind of look for signs and symptoms of the virus. As mentioned previously, so the University of Minnesota is involved in this work, the Minnesota Department of Health, Allina Health, and then it's funded through the Minnesota Department of Pediatrics and the Center of Disease Control and Prevention. So a little bit about the recruitment and the saliva collection. The research service, just approached the family on either postpartum or NICU units. 3 of our hospitals have NICUs, so we're able to enroll in those units. We just hand a family a 1-page flyer kind of talking about the study, and if they are interested, we go through the consent process with them. And then at that time, the saliva is collected from the newborn using a sterile polyester swab, where they simply are just swabbed on each of their cheeks for about 5 seconds or so. The study doesn't really try to make sure that a baby hasn't fed in the last 30 minutes, just to avoid any picking up of any CMV signal from colostrum, or we just kind of universally do it with any type of using formula or anything like that. About the notification process, so it's exactly the same as how the Department of Health does notification for newborn screening for this case, for those other 60 diseases and viruses I mentioned. So what they do is they contact the infant primary care provider or pediatrician. They tell them a little bit about the study. So since all the physicians in the state might not know about the study, they tell them a little bit about that, talk about that abnormal result, and then we recommend a pediatric infectious disease consult. At that time, then the provider would receive that research report, provider fact sheet, and then the fact sheet that they can share with the family who's being notified. And then the pediatrician would be in charge of consulting with the infectious disease provider and then also notifying the family. What they do at that point is also recommend a urine test to confirm the congenital CMV diagnosis. And here's just an example of that provider fact sheet. So again, it tells a little bit about like what CMV is, what they should talk to the family about, and then in the bottom right corner, you'll see about the false positive, like that can happen. And so that's really what we're focusing on here today. So I hand it over to Abbey Sidebottom, who's going to talk a little bit about our saliva test findings.
Yeah, so the data that I'm talking about runs from the start of the program in February 2016 through the end of 2019. And before we talk numbers, I just want to review some of the definitions that are used. So a saliva test is considered positive or abnormal if there is any CMV signal. There wasn't a cutoff point. And PCR is run in duplicate specimens considered positive if 2 of the 2 replicates are positive, or 3 of the 4 in cases where samples are tested twice. As Whitney mentioned, the positive saliva cases are referred to their pediatrician, and the pediatrician then will conduct a urine test to confirm the diagnosis. So true positive saliva results are those that have that positive clinical workup. And false positives are those where there was a positive result for the saliva, but the dry blood spot and the urine result were both negative. Okay, I'm going to go to the next.
I am trying. Let's see. Sorry.
During this time period, we enrolled 14,646 infants, and of those, 72 had a positive saliva test. 59 of those were identified to be true positives, and 13 were identified to be false positives. Now, one of the things we noticed is that these false positives happened in clusters. We had several that occurred within a week of testing, and then almost a year later, another cluster, and both of those clusters happened at the same hospital in the Allina Health System, Abbott Northwestern Hospital. And the other thing we noticed is that many of these false positives were giving a relatively low signal in the PCR testing process. So we started to dig in to try to, as a team, understand what was causing these false positives, where were they coming from. You can go to the next slide, Whitney. I think we ended up landing on investigating donor milk. You can keep going. And the thing that triggered our examination of donor milk was the fact that that first cluster had a set of twins. And in our hospital, often twins are given donor milk. So this caused the research associate who was helping dig into these cases to wonder if potentially we should look at whether or not these babies had donor milk. So we dug into the cases a little bit, into their chart, and found that of the 13 false positive saliva cases, 9 had used donor milk. Now, as I mentioned, most of these occurred at one hospital, the Abbott Hospital. There were 8 false positives, and 7 of those used donor milk, including that set of twins at the beginning. And we also noted that in that twin case, those samples were collected within that 30-minute window of feeding that we typically try to avoid. Sometimes it's unavoidable, and we document when that happens. At 2 of the University of Minnesota sites, there were 5 false positives. 2 of those cases used donor milk. There are 2 other hospitals, one within the Allina system, one within the U of M system, that didn't have any false positive. These sites do also use donor milk. At least for the Allina hospital, the volume is relatively low, so it might just be kind of a numbers thing why we aren't seeing anything there. Okay, Whitney, I think. So looking a little deeper into this association, we went back to all of the positive cases and looked at donor milk use and compared that with the false positives. Had 69% of the false positives had donor milk compared to 7% of the true positive cases, which yields an odds ratio of 30 with a really wide confidence interval. So it's not the most precise estimate. But clearly some sort of association going on there. And then Whitney's going to talk a little bit, because we wanted to dig into understanding a little bit more about donor milk.
Yeah, so these are just some of the questions we started to ask. We got just curious about, is it donor milk, and what do we know about donor milk, which we didn't know much at all. So just kind of a little bit of some background, some reasons that people might get donor milk, and this kind of associated with like the twins and things that we were thinking about. So, you know, when there's 2 babies, sometimes lower birth weight because mom's carrying 2 babies, or they might be born early. Sometimes, you know, they're getting donor milk because they're waiting for supply to come in, or mom's milk might be unavailable. Maybe mom's in the ICU or something like that, but they really wanted to have breast milk for babies. We wanted to see, does the donor milk that we get at that Abbott location, was it the same as what the University of Minnesota gets? Like, was it because of the donor milk we received, maybe? So they are different locations. The Alina used the Iowa and Colorado Milk Bank, and now they use the Minnesota Milk Bank. And then the University of Minnesota used the Mother's Milk Bank of the Rocky Mountain Children's Health Foundation, and then and the University of Minnesota Milk Banking. So, but that to say, all of them do include pasteurization. So we looked into all those milk banks, and they all pasteurize the milk. The milk is kind of stored together in like lots and batches. So it's actually several mothers that will donate their milk. It's all pooled together, and then that pasteurization occurs. So the pasteurization process actually, activates that infectious virus of CMV. So the baby can't actually get CMV or get infected from it, but that viral DNA might still be there, which could result in a like positive PCR signal, kind of like what we saw. And then just the milk is stored frozen on the postpartum units. There's some literature about fresh or frozen milk and things like that. So we kind of ask questions about that. And then kind of just who donates the milk, what is the kind of criteria behind that? We wanted to see, was there anything about CMV that the milk banks look at? So these mothers, are supposed to have a health and lifestyle screening, be pretty healthy, not use drugs, tobacco, alcohol daily, not taking herbal supplements, be willing to donate a certain amount of milk. It might vary by each milk bank. And then only take medications that are approved for safe for milk donations. And then again, of course, be low at risk, them and their sexual partner for HIV/AIDS and then other communicable diseases. And then be willing to take actually a blood test. So we did see that there was no mention on any of the milk bank websites about CMV screening of donor milk. But since our false positive cases came from that one hospital out of Northwestern, we decided we wanted to know how often is donor milk used by like the general population, and just looked at we delivered about 4,900 babies in 2018, and about 500 or 10% of them in 2018 used donor milk, and then 4,600 deliveries in 2019, about 13% used donor milk. So we started asking questions, kind of being curious about what we would find. So I'm gonna hand it over to Mark Schleiss, Dr. Mark Schleiss with the U of M. University of Minnesota here. What we did was send some of our batches of donor milk that was frozen on the unit over to the U of M lab to get tested.
Yeah, thank you, Whitney. So this is just a little snapshot of some PCR that we did in the lab. We used the same primer sets for real-time PCR, same primers and hybridization probes targeting the UL83 gene of human cytomegalovirus. We've had good success and sensitivity with both saliva and dried blood spot screening using this primer set. And we found, just in a sort of a quick snapshot here, 3 out of 7 of these batches were PCR positive for CMV DNA. These batches were not the same batches that were given to our babies that had false positive saliva screens. But I think it's a representative cross-section of what one might find in donor milk. And as Whitney alluded to, this is pasteurized milk. It is not milk that's associated with the risk of transmission. But it is not surprising, perhaps, to see that in healthy lactating women, that there is reactivation of CMV. We know this to be true from many studies going over many decades. And so this, as Whitney and Abby will circle back to, is a caveat to consider as we move forward with saliva-based screening at the bedside.
Oh, we did dig a little bit into the literature, and I think Mark, pop in here if you want to add stuff. But generally, what we found is that other studies have confirmed that viral DNA is present after pasteurization. We found a few studies that tested samples from women donating milk prior to that process of pooling and pasteurization that kind of documented prevalence of CMV. And as I think Whitney has mentioned, kind of there is kind of agreement that the immunomodulatory components of milk pre and post pasteurization has already been examined, meaning that it can't cause infection in the newborn after that. So I don't know if you want to hit the next. So this study examined milk, both bacterial and viral analysis of unpasteurized milk from women who were donating to a milk bank and compared it to samples that were purchased over the internet. And they noted that they found 21% of the internet samples were CMV positive compared to 5% of the milk bank samples. Really, the focus of this paper was more about the bacterial content as well, but that was an interesting finding about the lower rates for the women donating to the milk banks. And then a study in Oslo, which was really focused on kind of informing policy for feeding very low birth weight infants. They also looked at donors that had been tested for CMV during pregnancy. So they're not actually testing the women's milk, but they are testing the women, and found that 2/3 of the women were positive during pregnancy. And I think, Mark, maybe you can weigh in on how that compares to the general prevalence you would expect.
Yes, thank you, Abby. So the prevalence of CMV antibodies, of course, is highly variable around the world. Essentially 100% of women of childbearing age, lactating women in Africa, most of Asia, South America, are CMV seropositive. In the United States and Europe, it ranges in the 40 to 60% range. I would fully expect, based on the work of people like Klaus Homprecht in Germany, Suresh Bopanna and his colleagues in Birmingham, we would fully expect that any CMV seropositive woman, that is to say, any woman who's got antibodies, would reactivate CMV during lactation. Not all women transmit, but many do. And in the global sweep of all of human history, I dare say that most people on the planet have had CMV, and most people probably got it from breastfeeding. But this is important in the context of our discussions about newborn screening, simply because it does create the potential for false positives in saliva-based screening programs. The one comment I would add here before I turn it back over to you, Abby, is that one might say, well, donor milk doesn't normal milk during lactation also run the risk of giving you a false positive saliva swab. But the important caveat here is that colostrum doesn't tend to contain much CMV DNA. It really isn't until week 2 or so of lactation that you begin to see CMV in the breast milk. So a mom in a newborn unit who's beginning to breastfeed, that baby would be less likely to have a false positive than a baby who's being supplemented with donor milk. I'll turn it back over to you, Abby.
So the next study that we identified was one that used data from the NCHAM study to calculate their false positive rate for saliva testing specifically. And then they tried to estimate how that rate might be affected by breastfeeding. So they had 74,000 infants tested, and 370 of those gave a positive saliva result. 23 were determined to be false positives, which they identify as a rate of 0.03%. They also noted that the viral loads on those false positive cases were lower, so similar to what we indicated in our study. They did not actually have data on seropositivity of the mother or breastfeeding status. So they went out and used national data for different racial groups that were represented in their study to collect information on, or to provide estimates on those things and apply it to their population by racial group. In the end, they kind of came up with adjusted false positive rates that ranged from 0.05 to 0.14%, depending on which group. And they just kind of concluded that breastfeeding the first week contributes to low but acceptable false positive rates for saliva. I don't know, Mark, do you have other thoughts on that particular study, or what it implies?
Well, I think that this is very important information from the CHIME study. As you alluded to, the best estimates of breastfeeding were reconstructed from national data and national norms. And our false positive rate, when we looked at the total denominator of babies screened to date, and our updated number is just under 17,000 as of 11 o'clock this morning Central Time. But our false positive rate is pretty similar to that which was described in the CHIME study.
Mark, do you want to just go over the final kind of implications?
Sure. Donor milk, very, very important source of nutrition, particularly valuable in our very low birth weight premature infants. We know that pasteurization of milk is an effective modality to inactivate infectious agents, and in particular viruses. The problem of cytomegalovirus transmission in very low birth weight premature infants continues to be a vexing one for neonatologists, and it is continually debated in the literature and in the field whether the benefits of fresh milk, that include cytokines, lactoferrin, leukocytes, antimicrobial peptides, outweigh the small risk of CMV transmission and attendant disease that might be associated with fresh milk. And so we continue to, I think, look at this issue and try to decide what's best for our premature infants. In many places in Europe, it's a standard of care to pasteurize milk before giving it to very low birth weight preemies. The Red Book Committee from the American Academy of Pediatrics has in the past recommended freezing milk at -20 degrees centigrade to inactivate viral infectivity. But it's been more recently shown that this doesn't completely inactivate the virus. So these are some of the issues, I think, when we talk about pasteurization and infection in the newborn. But we're not talking about preemies today. We're talking about term babies, and we're talking about universal congenital CMV screening. And so I think the real issue is that we need to interpret positive saliva PCRs cautiously, both in breastfed babies and as Abbey and Whitney have shown, in particular in babies that have received donor milk in the immediate newborn period. Again, emphasizing that donor milk is from women who have established lactation. It's not colostrum, it's not transitional milk, so it's more likely to have CMV genome. This is not a safety issue at all for the baby because there's no transmission of infectious virus. But it does complicate our assessments of newborn screening with saliva-based protocols. We know, for example, that there's a now commercially available bedside CMV diagnostic system manufactured by Alethea, and this is being used actually in some nurseries now in the United States. And my recommendation, until we have better data, would be to confirm any positive saliva screen with a urine CMV before making a judgment about whether a baby has congenital CMV infection. I think this is very much in keeping with established principles of newborn screening, where we accept a modest or even high false positive rate if we know that we're not missing any newborns. But I think it's premature to say that a PCR-based saliva swab unequivocally confirms the presence of congenital CMV I think we need to focus on blood spots and or urine as really the gold standards. And I think the data that Whitney and Abbey have put together and presented here today reinforces that one might interpret a saliva PCR cautiously, particularly under circumstances where a baby has received a donor milk. So that is the extent of my comments about this, and I'll turn it back over to you, Abbey and Whitney, to finish up.
I think that's it.
This was very interesting for me as a parent, I must say. I had so many thoughts racing through my mind, and I think you summarized a lot of them at the end. One is I remember for all these years thinking we got to be careful with saliva because of, breastfeeding. Well, you mentioned a great point that I didn't know about the colostrum and the CMV now. So it might not necessarily be, now you guys are uncovering data that's showing that maybe it's donor milk or maybe it's other things. The other point I really, really think is important, Dr. Schleiss, and you mentioned it, is that yes, we do have false positives, and we know we're going to have false positives. But as a parent, I feel like it's a small price to pay to get a second, whether it's urine or however they do it, to kind of verify that false positive. And the worst case for those 13 babies out of 15,000 births is that they had to do a urine test after to find out that they in fact were, the child was in fact CMV negative. 13 babies on 15,000 had to go through that traumatic experience, I'm being sarcastic here, of getting a second, whereby we identified 56 true positives at a much higher rate, I think, right, Dr. Schleiss, than we would if we were using any other method. Mm-hmm. Yeah.
Thank you, Rob, and thanks for that personal perspective. And I agree with you, and I think that's a really important point. I would add that we also can think about bedside screening in the newborn nursery in terms of cost to the healthcare system. And we have to balance sensitivity with the risk of false positives. Certainly a bedside saliva screen processed in a sort of automated point of care diagnostic system is much, much cheaper for the healthcare system overall than bagging a baby for a urinalysis, which takes a lot of time. And in the United States, anyway, the most costly thing in our healthcare system is the cost of people's time. So I think that's another consideration. I would also comment that another competitor, Diasorin Laboratories, has rolled out a bedside CMV saliva PCR diagnostic system. And there was data presented at the Congenital CMV workshop, which was remotely held from Paris last month, also showing that that's a useful system. And it'll be interesting to see if that system becomes a competitor for the Alethea system in the United States and Canada.
Well, for me, I'm excited because, as I mentioned earlier, I think in the show, we now have a universal CMV screening bill on the table in Manitoba. First reading passed, second and third reading coming in March-ish. So really excited about that. And it's a saliva-based bill. So that's pretty exciting. Your opinion, Dr. Schleiss, it has been reinforced on the gold standard, correct? I don't want to put words in your mouth, but I think you said that earlier, right?
I would say that, again, based on the work of Suresh Bapana, Karen Fowler, colleagues in Birmingham, and a number of really landmark publications coming out of that study, that we would consider saliva to be a gold standard for diagnostics. I will also comment, though, and we've presented this data, and the manuscript will be out just after the first of the year with my main collaborator, Sheila Dollard at the CDC. We will be reporting on significantly enhanced sensitivity of dried blood spots. And so, I think this will be an ongoing discussion. And the potentially very elegant use of dried blood spots comes from the fact that they're collected on most newborns anyway. And so there's really no extra work at the bedside. And in collaboration with the Minnesota Department of Health, and in particular Mark McCann, the newborn screening program director there, and Sandra Rosenthal, who's the lead coordinator of the study in St. Paul, Minnesota. We've developed a pretty seamless and efficient way to inculcate the information from the dried blood spot analysis into newborn CMV screening. So maybe we shouldn't let the perfect be the enemy of the good. If we can achieve a 85% sensitivity with dried blood spot based screening and piggyback on established infrastructure and resources to process dried blood spots, as they do in Ontario,
That's right.
then that's a dialogue that needs to continue, in my opinion.
I was a big believer as a parent advocate for the longest time that you need wins. You need wins, and if that win means piggybacking, getting slightly less sensitivity, missing some babies, I get it. We don't want to miss any babies, but we're missing pretty much all of them right now. So I, as a parent, was a big advocate of, let's piggyback, let's get wins, let's expand it a little bit. If we could tack onto the dried blood spot, great, let's do that for now. I mean, we do have a vision for a world without congenital CMV infections, which includes universal screening and of the gold standard, whatever that may be. But that's a very good point, Dr. Schleiss, and one that I would definitely echo. Let's get the wins in the back pocket, and let's start lining up the wins so that everyone awareness raises, right? If we start actually getting 85% of babies universally, well, a lot more people are going to hear about CMV. A lot more people are going to be contacting their senator, their legislator in Canada. A lot more people are going to start lobbying. A lot more people are going to donate. A lot more. We just move the needle a lot quicker. So let's get some wins. Let's get some wins. And I say this as an advocate. I think it's phenomenal work that you guys are all doing. Thank you for this research. Thank you for the time you've put into this. Dr. Abbey Sidebottom, Whitney Wunderlich, Dr. Mark Schleiss. For me, as an advocate, as a parent who's had to sit in the hospital and see my son go through this, I'm thankful for the research that you are doing, and I'm thankful so that other parents are not going to have to go through that. So my kid's doing great. It's not about him, but I'm incredibly thankful for the work that you're doing. Thank you for dedicating pretty much, in your case, Dr. Schleiss, anyways, you're pretty much your entire professional career to CMV. So thank you for that. Again, I want to thank our sponsors. We're running high on time here, so I would want to ask more questions, but I do want to respect the time as well. This is the CMV Public Live series, CMV Live series, CMV Canada, Merck has always been really good to us, National CMV Foundation, and NCHAM. Thanks so much. We're back in 4 weeks on Wednesday, January 6th, and the chat is going to be on, I got it right here, I promise. It's provider testing practices for congenital CMV infection. Consistently inconsistent. That's like my golf game. All right, guys, thank you so much. Anyone last words? Otherwise, I just want to thank you so much for your time.
Thank you.
Thanks for having us.
Okay, thanks, guys.
And I would echo that. Thank you so much, Rob, for your advocacy and your great work up there. And glad to be a part of it, and always happy to help any way we can.
Thanks so much, Dr. Schleiss. I will see you in Ottawa, right?
Yeah, I hope so.
You guys coming to Ottawa? Wendy, Whitney, Abby, you guys coming to Ottawa?
Maybe.
Putting you on the spot.
We'll figure it out.
We'll see.
Okay, right on. Thanks so much, guys. Have a great day.
Thank you.